Hi everyone, and today we'll be discussing about skeletal muscle relaxants. Okay, and as usual, before we get into the topic, we'll see the basics. So, how are skeletal muscles actually contracted? For that, we'll have to go into the uh, neuromuscular junction. Okay, so what happens is uh, if we want to contract a muscle, the CNS sends signal to the nerve ending and asks the nerve to release acetylcholine. Okay, this goes and reacts with the NM receptor. When it reacts with the NM receptor, it allows, it makes the muscle fiber to allow sodium to enter into the muscle. And when sodium enters, calcium also enters from outside, and that causes the sarcoplasmic reticulum. See, the sarcoplasmic reticulum in the muscle fiber, see over here, it has a receptor known as the ryanodin receptor, which gets activated and it releases calcium ions. Okay, and these calcium ions acts on the myosin and actin fibers, and that thereby causes muscle contraction. Moreover, this acetylcholine release is actually promoted by polysynaptic reflexes, which is sent by the CNS. First of all, what is polysynaptic reflexes? Huh? So, polysynaptic reflexes means poly means many, right? Many, and synapses more than one synapse is present, and it's a reflex. So what happens is when there's a sensory stimulation like heat or cold or touching of a sharp object, that information passes via the sensory neuron and it enters the interneuron. This is one characteristic feature which is present in the spinal cord. Okay, from the interneuron, instead of going it to the CNS, it goes to the motor neuron and reaches the muscle and causes muscle contraction. Okay, so one of the main examples are withdrawal reflex. Okay, withdrawal reflex. So to inhibit that muscle contraction, we use drugs known as skeletal muscle relaxants or SKMRs. You see, these SKMRs can be divided or classified into centrally acting and peripheral acting, and these peripheral are moreover divided into directly acting and indirectly, and then indirectly there are the depolarizing and non-depolarizing types. So let's go into the central SKMRs. So these central SKMRs, they inhibit the polysynaptic reflex and causes CNS depression. You see this over here, this one. So the central SKMRs, they decrease the tone of the muscle, and there's actually no effect on the voluntary power. That means that individual will be able to move his arm and do all the functions in a regular basis, but those reflexes will be diminished. And one of the adverse drug reaction is the sedation, right? Right. So one of the the central SKMRs, those can be used for acute muscle spasms, like we get all these handshakes and all that, and then backache. When there's a backache, it is usually caused due to very tight muscle contraction in the back, or torticollis. That is one of the defect where the sternocleidomastoid is abnormally contracted. You can see in a normal individual how the sternocleidomastoid is present, and in a torticollis patient how it is contracted, right? And then lumbago. What is lumbago? Lumbago is nothing but lower back pain which we have. Okay, and then during anxiety and tension, for that particularly BCDs or like diazepams are given. Okay, and then for spastic neurological disorders like cerebral palsy. Cerebral palsy is is the disorder of the movements, muscles, and posture and tone of an individual. Okay, so the movements are abnormal, muscle abnormally contracts, and there's different tone, posture is really varied. You see this person, do you remember? He is actually seen in Breaking Bad, that Junior Walter person. He has cerebral palsy, and it is used to treat electroconvulsive therapy. After ECTs, what happens is the person undergoes very major muscle contractions and abnormal muscle contractions. To prohibit that, central schemas are given. CSTs or ESTs or electroconvulsive therapy is given as a last resort to treat severe major depression and bipolar disorders. You see in these movies where they keep shocks to certain people and all like that. And in tetanus infection, as you know, in tetanus infection there is it's a bacterial infection which causes a lot of very tight muscle contractions, right? And it is also used during orthopedic manipulation. What is orthopedic manipulation? It is basically these small procedures which people do, right? Like small dislocations and all happens. For that, we use central SK Other examples are alpha 2 agonists like tizanidine and GABA B agonist like baclofen, which is used to treat spasms and hiccups. I mean, hiccups are normal, but when continuous hiccups happen, which is not usually preferred, so it is given. And BZDs, and then these central SKMRs actually increase GABA, such as the drug thiocol and some mefenacin derivatives. And if you see all these examples, all of them suppress the activity of the CNS. Okay, and this is central SKMRs. Now we'll go into the peripheral SKMRs. In peripheral, we have the directly acting dantrolene and quinidine. You see these dantrolene, these directly inhibit the rhinodinic receptors. So it is used for treatment of neuroleptic malignant syndromes and malignant hyperthermia. Okay, what are these diseases first of all? In these diseases, what happens is firstly, these D2 receptors are there, right? These are blocked, and that blockage causes increase in the rhinodine action. When rhinodine is increased, as you know, these rhinodine receptors are stimulated, and from the sarcoplasmic reticulum, more calcium is released. Okay, and these calcium causes more contraction. And whenever when we feel cold, right, what do? We rub our hands, and we try to do some exercise to raise our body temperature. So that is actually happening because muscle contractions in turn produce heat. So what these datrolene, otherwise it's commonly known as datrolene sodium, this goes and inhibits the rhinodine receptors, thereby blocking the calcium to come out from the sarcoplasmic reticulum, thereby stopping muscle contraction. Right, so this is directly acting. Now indirectly acting. These can be classified into depolarizing SKMRs and non-depolarizing SKMRs. So in depolarizing, one of the main example is succinylcholine. You see in this NM receptor, what did we say? When acetylcholine comes and acts, when there's one receptor, ACH or acetylcholine comes and acts on the NM, and it causes sodium to enter into the muscle. Acetylcholine and succinylcholine are somewhat similar, okay, but what is that the succinylcholine has a very long duration of action. So what happens when succinylcholine is given, it goes and attaches to the NM receptor and causes more number of sodium ions to enter into, and that causes muscle contraction. Okay, and rapidly what happens, initial fasciculation, that is when we do more exercise, what happens? Our muscles start to pain, right? That is because we contract our muscles more. We do a lot of reps, a lot of push-ups. If we do, what happens? Our muscles start to pain. That is what is happening over here. The succinylcholine, as soon as we give it, what happens? Our muscles act a lot, it contracts a lot, and thereby it releases potassium also, which can be an adverse drug reaction, which may cause hyperkalemia, which is dangerous for cardiovascular patients. So when there's more number of sodium entered into it, our muscles become sore. And after that, what happens? When a stimulation is given, the muscle becomes desensitized. The muscle becomes desensitized, which means that it won't be able to accept any more stimulation. That causes a flaccid paralysis. What happens? That muscle becomes weak and it just floppily falls down. So it is mainly given during intubations. Why is it mainly preferred during intubation? Is that succinylcholine, its duration of action is like 5 minutes, and the onset is in 1 to 1.5 minutes, which is really important during intubation, right? The person is actually not able to breathe, so we need to intubate him as soon as possible. For that, we use this succinylcholine, and in 1 to 1.5 minutes itself, it will become relaxed, and then we can intubate him. One of the adverse drug reactions is that it increases intraorbital pressure and can cause malignant hypothermia. So for that we can use datrolin to treat it. That is, malignant hypothermia comes when people have a defective ryanodine receptor mainly, and it increases intragastric pressure. So yeah. So what happens is that during this, even muscle injuries may happen because of a lot of contraction. Muscle injuries and nerve injuries may happen. Why is that so? And people may even experience apnea. We are using this to treat apnea, right? We are using it to use intubation and treat apnea, but it may cause apnea in some people. Why is that? Because you see, normal people, the succinylcholine is metabolized by the typical pseudocholinesterase enzyme, and it gets inactivated, so no apnea will occur. But in some people, what happens is they have atypical pseudoapnea. In that case, what happens? Succinylcholine doesn't get fully digested, so that will cause a longer duration of action, thereby causes paralysis of the diaphragm. That is very dangerous, right? So the person won't be able to breathe itself, because diaphragm is one of the main muscles of respiration. That causes succinylcholine induced apnea. So for that, treatment is ventilators, and fresh frozen plasma can be given, or recombinant pseudocholinesterase can be transfused into the person. To check if that individual has a typical or an atypical pseudocholinesterase, we use the Debukine number. So what is Debukine number? First of all, it is the percentage of pseudocholinesterase inhibited by the Debukine. So in normal individuals, the Debukine number is 80. For in heterozygous conditions, it's 50 to 60, and for homozygous, it is 20 to 30. Okay. So that is depolarizing SKMRs. Now we'll see the non-depolarizing SKMRs. See, these non-depolarizing SKMRs act on a principal function by competitive neuromuscular blockers. They are competitive. See, they fight against the acetylcholine, and they go and attach to the neuromuscular receptor. And directly what they do is they don't allow the sodium to enter inside itself. In depolarizing, what happens? It actually allows more sodium to enter, but in this it doesn't allow at all. So what happens is it competitively inhibits. It's just competitive inhibition, that's all. And thereby what happens is, when in due time, what happens, acetylcholine concentration increases. So therefore it can competitively again come back and attach to the NM receptor and cause contraction as usual. So for reversing this competitive neuromuscular blockers, we use neostigmine, because we can't actually give acetylcholine directly to an individual. This neostigmine is given, which will go and attack or bind to the anticholinesterase and increases the action of the acetylcholine. So now in non-depolarizing SKMRs, the drugs which are available, those are isoquinoline derivatives and the steroidal drugs. Okay, so first we'll see the isoquinoline derivatives. One of the main examples of isoquinoline derivatives is the DTC or D-tuberochrine. Okay, that causes increase in histamine. Increase in histamine release, which causes increase in BP, allergic and itching reactions, and it blocks also the NN and ganglionic blockers. And then the other examples are metacurium, atracurium, and mivacurium. Okay, mivacurium is the shortest acting non-depolarizing SKMRs. Okay, all of these examples cause histamine release, therefore causes allergic reaction, allergic reactions and all that. But the other examples, cis-atracurium, doxacurium, invigatocurium, these all does not or releases very less histamine. So these are more preferred. And doxacurium's T half is like 2.5 hours. So its duration of action is very, very high. It's the longest actually. You see, this atracurium and the cis-atracurium, is that right? Both are kind of the same. These both undergoes Hoffman's elimination. What is actually Hoffman's elimination? This is one type of degradation or metabolism of a drug. When a drug is there, it has to be metabolized either in the liver or the renal system, right? But what happens when a patient has renal failure or hepatic failure? So we can't put a lot of stress on the liver and kidney. For that, these drugs are, these two, atracurium and cis-atracurium, are preferred because it undergoes Hoffman's elimination. Hoffman's elimination is spontaneous and molecular rearrangement. Basically, it degrades on itself. So yeah, these undergo spontaneous and molecular rearrangement. So it is safe to use in renal and liver failure patients. So these SKMRs, what are its uses actually? It's used in SKMRs are used in general anesthesia. And after anesthesia, for the reversal, we use neostigmine, which increases the action of acetylcholine. And then it is used for intubation and used for assisted ventilations. And when individuals come with convulsions and trauma, when individuals have convulsions and traumas during an electroconvulsive therapy, we can use it. And in severe cases of tetanus and status epilepticus, SKMRs are used. So yeah, that is about it. And I hope you enjoyed this video and it was really informative for you. Thanks for watching, and make sure to definitely like this video and to share it with your friends and whoever needs to know about skeletal muscle relaxants. And don't mind and just leave a comment or leave a nice heart in the comment section. And make sure to definitely make sure to subscribe, because I am going to be making a lot of interesting videos and I hope it's gonna be useful for you. So yeah, thanks for watching and I'll see you next time.